Okay, good. So I guess now it's time. It is 2 minutes past the time, so I think we can start. And we already have a lot of people joining us, so I think we could actually start. So yeah, thank you very much for joining us, and good afternoon for those who are in Latin America and in North America. As every month, it's a pleasure for me to be hosting the LACES Grand Rounds. So today we have the presentation from Gustavo Prieto and Lorena Montes from Colombia. They're going to talk about complex reconstructive surgery for severe infective endocarditis. And we have the great pleasure and honor to have the presence of Piroze Davierwala. He is a consultant in the Toronto General Hospital, and maybe one of the persons with the greatest experience performing the UFO or commando surgery, which is well known for this kind of complex reconstructive surgery. So Piroze, welcome and thank you so much for joining us. And you are the moderator, so you have the word and you can just start the meeting.
So thanks a lot, Matteo, for the kind invitation on this very important topic, which is not very common, fortunately, in the lives of most cardiac surgeons. But all the same, it is extremely important because it is one operation which can really get you out of trouble, you as well as, I mean, more importantly, the patient. This surgery, I had the honor of or the privilege of learning this operation actually from one of my mentors, Dr. Tyrone David, with whom now I have the pleasure of working with in the same division. And that's how the journey for me regarding this operation started off. And that really helped me in performing this operation in Leipzig, where I was for the past 12 years. Because we used to see a ton of patients with complex or complicated endocarditis who actually required this sort of operation. And this is one operation which obviously is complex. It is a difficult operation, but it is sort of the only solution for some patients who otherwise normally would not survive the disease itself. So just with that short introduction, it'll be great to hear Dr. Gonzalez and Dr. Villalobos talk about complex reconstructive surgery for severe infective endocarditis. And once they've done with it, we can have a good, healthy discussion about different technical aspects, probably indications besides endocarditis, where this operation can also be helpful, and so on. So it would be my pleasure to invite Dr. Gonzalez and Dr. Villalobos to start with the presentation.
Okay. So hi, I am Dr. Lorena Montes Villalobos. I am a cardiovascular surgeon in Colombia. We work, Dr. Prieto and I, we work in Cali, Colombia, in the Hospital Universitario del Valle. And we also are part, we form a group that is called Corbita. And we have our surgery in different places in Colombia. In Pasto, in the Unidad Cardioquirúrgica de Nariño, and also in the Hospital Universitario Hernando Moncaleano Perdomo de Neiva. Our agenda today will be a review of complex infectious endocarditis, and not just about the commando procedure, but the different procedures that we can perform with this type of disease. Also the cases of interest that we have, and to finish the commando procedure, our experience. So we'll start with this review. So most severe and devastating complications of heart valve disease, native or prosthetic, is an infectious endocarditis. And now with the possibility of having another cardiac devices like defibrillator or a pacemaker, well, it's increasing. It's fatal if not treated, and the early diagnosis is crucial. Also, we have in our armament antibiotics and also surgery. It's we've been seeing that it's increasing, the prevalence and the incidence has been increasing in the last years. And now we have like 43,000 cases per year in the United States. And mostly because of an augmentations in the Staphylococcus aureus population that has infectious endocarditis. The mortality rate is still very high, of 20% to 30 days and 30% at 1 year, or 45% at 5 years. And the related stroke to endocarditis, still 15.8%, very high. And the need of surgery is in 30% probably of the patients. The pathophysiology is important to see this theme that we are talking today about the complex endocarditis. So first of all, we have circulating organisms like bacteria, and they have adherence. Adherence to what? To endothelium that is damaged. So when this adherence gets to this endocardium or these places with damage, like a valve that it has a disease, the formation of vegetations start. These vegetations cause embolization, and also it can cause a stroke, myocardic aneurysm, and related phenomena. These related phenomena can be like a pericarditis, hemorrhagic pericarditis, for example, and also arteritis. Also, this circulating organism can, they release enzymes and toxins. These enzymes and toxins invade and also cause tissue degenerate disintegration. And this causes paravalvular abscesses, fistulas, heart block, and valve regurgitation. This is this last part is what we are talking about today. So this constitutes a very complex endocarditis that needs a very high skills in the surgical theater to have a good result. So what is a complex or a complicated endocarditis? So the embolisms, related phenomena, as I said before, and myocardic aneurysm that can appear very long time after the endocarditis was treated. Also valvular destruction in the leaflets that are susceptible to repair. So this is a very complex endocarditis that we can actually try to save this tissue. And paravalvular abscesses and fistulas. So the guidelines started to speak, it's been like 5 years, about a multidisciplinary endocarditis team. And it's formed by cardiac surgery, infectious diseases specialist, also an addiction specialist, because now, especially in the United States, they're having this problem with drug addicts. Also a neurologist because of stroke and the very high risk of stroke, a radiologist, and cardiology. The other thing that the guideline addresses is the patients should be referred to a third level center or a big center that is specialized in managing this kind of pathology. And in Latin America, sometimes it is very difficult to get this, to try to send the patient to a very specialized part, because we have very places that are very far away from these specialized centers. The indications for surgery are heart failure, pulmonary edema, or cardiogenic shock, left-sided endocarditis by Staphylococcus aureus, fungal or very resistant bacteria, annular complications and heart block, persistent infection that it's more than 5 to 7 days after antibiotic started, And the persistent infection is they still have bacteremia or fever. Relapsing infection in prosthetic endocarditis, recurrent emboli with large vegetations, and these large vegetations are more than 10 millimeters in the left side, or more than 20 millimeters when it's the right side. When is the time of surgery? So now we have this question that it's been trying to be answered for a while now. And if you do it too late, you have the problem of embolic events and sicker patients, and also the catastrophe of finding the destruction of, for example, the fibrous body. And if you do it too early, you will have complications like hemorrhagic stroke or poor control of the infection at the time of the surgery. So this is a meta-analysis that was published in 2016 about when to intervene. So they defined the early versus late surgical intervention, and they had this definition of early when it was 20 days before 20 days of the start of the diagnosis. And they found that the mortality was lower if it was done early. This is probably because, sorry, I will back. Yeah, probably because the embolic events were also favored the early surgery. So the guidelines, right now, we don't have a consensus that in what is early surgery exactly. That this meta-analysis will less than 20 days since diagnosis, and the guidelines actually they speak about during the definition in the guideline is during initial hospitalization before completion of antibiotics, and it's probably 2 weeks in almost every case. And the AATA's guidelines for endocarditis, they talk about emergent surgery or very early, that it's less than 48 hours. This is an organigram that it's for me pretty clear of when to do it. So we have all these complications, valve dysfunction, resistant organism, heart block or abscess, persistent infection, relapsing PBE. And it all goes to surgery, early surgery always. The only one that has a delay surgery is when you have major ischemic or intracranial hemorrhage. So you can consider delaying the surgery for 4 weeks. But if you don't have, if you have a stroke, but you don't have very extensive neurologic damage or hemorrhage, you don't have to delay the surgery. And this is, why is this? Because you can have these catastrophes like in this paper where they describe this mitral vegetation, large vegetation. They had this related phenomena like hemorrhagic pericarditis. And when they explore the valve and the heart, they found these abscesses here at the atrioventricular groove. This is inside, and they had to resect this with all the complexity that and the high mortality that this situation has. It's a catastrophe. And about the complex surgery of endocarditis, so what does the literature says? So this group from Leeds published 59 patients from January 2005 to December 2007, and they had only patients with intracardiac abscesses. So they had to perform different kind of surgeries, double valve changes, aortic root replacement, and they had this mortality. So it's a pathology that has a very big mortality, very high mortality. So in hospital, 23%, and at 10 years, 66% of the patients were dead. This other paper is from China. It's 57 patients and more of the same. So the operative mortality is high, 11% patients die in the OR, and also 66% at 10 years. So, and finally, Dr. Davierwala, who's with us now, published this paper about the 5 years outcomes following the commando procedure, or UFO, as UFO, as they say in Leipzig, they call it in Leipzig. And they found the mortality was pretty high also. At 30 days mortality, it was 28% of mortality, and at 90 days, 37%. But once the survivors passed these 90 days, they had a pretty reasonable survival. So now we're going to speak about, well, to present some of our cases, 8 cases of interest. All of these cases are ours from our practice. So we hope you enjoy, and feel free to ask anything as in the middle.
Okay, our intention with these cases is illustrate different scenarios in the surgical approaching of complex endocarditis. The first case is a 41 years old woman. She consulted for 3 months of night fever and chills, weakness, weight loss, and she has blood cortisol positive for Streptococcus sanguis, and transthoracic echocardiogram showed a tricuspid valve vegetation, so she was referred to our center. In transthoracic echo, we found a huge vegetation in tricuspid valve, and TOE showed a more complex lesion with maybe abscess and vegetation. So we went to surgery, and we found in the right atrium a big mass added to the anterior tricuspid leaflet that we opened, and we found an actual hole to communicate this to the aortic root. So we had a fistula between aortic root and right atrium. So this is a video of surgery. This is the right atrium view. We can see the pseudoaneurysm and the fistula coming from aortic root. So we went to an aortotomy. We explored the aortic root, and we found a big hole just in the non-coronary sinus. And our approach was try to preserve aortic valve, so we tailor a pericardial patch in order to correct the defect in the aortic root with a Prolene 5.0 running suture. Make sure that didn't injure the aortic valve, and avoiding any redundancy or discrepancy in the tissue to preserve the aortic root configuration. Then we went to the right atrium, and we used again a pericardial patch in order to correct the defect, the right atrium defect, to avoid residual shunts. We use again a 5.0 Prolene running suture. After that, our intention was to preserve tricuspid valve, so we implanted a tricuspid ring. Tricuspid valve looked with good tissue, enough tissue, But when we did the water test, we found a significant regurgitation because retraction of the leaflet. So we decided to use a field stitch between the anterior and posterior leaflet, trying to correct the situation. And then we include the septal leaflet. At the end, we had a tricuspid valve and 3-hole valve, but with good performance. Then we went to aortic root to explore aortic valve, and we found good function, good coaptation. So we decided to end the procedure. Perioperative echo showed a significant tricuspid regurgitation, no stenosis, and aortic valve normal function without any residual fistula or shunt.
So, Gustavo, I don't know, do you want to maybe discuss the cases after every case, or do you want to wait until the end? What do you prefer, Piroze? And Gustavo and Lorena?
I think it's better to discuss the cases after every case because
okay, great. So there are actually
it will be lost.
Yeah, sure. I think it makes sense. There are actually 2 questions in the chat, so I will read them out loud, and then Piroze and Gustavo and Lorena can answer them. So the first question is from Juan Contreras from Chile. He's asking if the patient had a ventricular septal defect before.
No, he didn't. In fact, the color flow didn't show any abnormal flow. It was a surprise for us when we opened and find out.
Okay, great. And now it's a question from Mariano Branchik. He's congratulating you and saying that it's a very interesting case. And then he's saying that, or commenting that there is as well another technique that joins the 3 valves of the tricuspid valve. It's called the Clover technique. It's similar to what you did. Do you know that technique, or do you have any experience with that?
No. No. Maybe.
Well, that is similar to the, it's just a similar to the Alfieri technique for the mitral valve repair. So you take a stitch at the, on all the 3 leaflets, just like you take for the mitral valve. And that sort of repairs the valve.
Kind of what we actually did.
Yeah. I called Alfieri stitch, but I didn't know the real name.
So my question to you is, like you did a patch for the aortic valve as well, right? In that video.
No, just the non-coronary sinus.
Sinus.
The aortic valve was good.
Okay. Suppose you have a defect in the cusp itself, would you extend that patch into the cusp, or would you just do a valve replacement?
I think if the lesion is just in the leaflet, we try to correct with a patch. But if the fistula is in the leaflet and the aortic root, maybe we go to replacement.
Okay. And many times you have to be also aware that the abscess looks very benign initially, just on the tricuspid valve, but it sometimes extends into the central fibrous body. And that really makes the operation very difficult, because in that situation you have to really go ahead and do a commando operation, because it involves basically all the three valves which are connected to the central fibrous body. So it's very important to do complete debridement. Sometimes you feel, oh, this is only a small little nubbin which you can remove. But that keeps going deeper and deeper, and you have to follow it and excise everything. Otherwise, you'll just do a sort of a valve repair, and the abscess will be as it is, because you won't be able to see that abscess with your bare eyes unless you go deep into the tissue.
Okay. Any other question? Or we go to the second case?
I think that's it. I think you can go ahead. There
Yeah,
are
go
no
ahead.
more questions. Yeah.
Okay, so this is a female patient of 44 years old, and she consulted because she, in the past 4 weeks, she had disorientation, dizziness, and visual defect with hemianopsia. And when she got to the hospital, they heard a cardiac murmur. But in that time, they were completely focusing the patient to a neurological problem. So she went to a CT scan, and she had edema and a possible occipital tumor. So neurosurgery programmed her for a biopsy with stereotaxia. And when they did the biopsy, they found an abscess, and the culture of that biopsy showed an Staphylococcus aureus. So at that moment, they decided to do an echocardiogram because the most probable etiology was endocarditis. And as you can see here, she had a severe mitral regurgitation, very eccentric, and it seemed like just, going in through the leaflet. So in the 3D echo, we could see it was a pathological valve, and we had this perforation here. And you can see here the jet just going through the leaflet and causing this severe mitral regurgitation. When we went to the OR, we found exactly that. So she had an endocarditis, and she had inflammatory tissue, but the valve was looked pretty preservable, and we had this perforation of the posterior leaflet. So what we did in this case, and sorry, we don't have the echo the echo after the surgery, but we did also, we tailored a patch, and we did a patch repair of that little perforation, and we put an annuloplasty ring because the valve was kind of myxomatous, but the result was pretty successful. And then the patient, her evolution was pretty good, and she just had her antibiotic finish, and then she went home, and we saw her in consult like 2 weeks ago, and she was very good right now. So I don't know if anyone has a question about the second case.
Yeah, I actually do. It's very interesting that the patient was first operated in his head, he has a neurosurgery. So I actually wanted to ask you about the timing, because I mean, after opening your cranium, you have the risk of bleeding. So I wanted to ask you, how did you plan the timing for that operation? And when did you do it actually? Like how long did you wait for the operation?
We waited until 3 weeks because the patient was pretty stable, 3 to 4 weeks actually. She was pretty stable and we were monitoring her. And the bacteremia was already controlled. She was in antibiotics. She was requiring anything for heart failure, but she had this image that is exactly in the echo 3D. I think it's
actually we got some problem to define the timing, because this first image looked like a cavity over here, maybe an
abscess.
So it was difficult, but the recent brain surgery, but the stability and the good response of antibiotics
define the
timing.
Yeah. So the patient, she wasn't in heart failure. The bacteremia was completely controlled. She had no fever, no SIRS, no anything at that moment. But I think it's very interesting. The echo 3D was showing us exactly what we saw in the OR. It was just exactly that. And when we went to the OR, we were very worried about her bleeding because she had just recent biopsy. But the evolution was very good. She didn't have anything in her neurological state. So anything worse. I mean, she didn't worsen. So
here you were actually quite lucky that the pathology itself was not that bad as far as the mitral valve was concerned. Being Staph aureus is pretty notorious, and usually you don't have the luxury to wait like for 4 weeks with a Staph aureus. And it always becomes a problem when patients with Staphylococcus aureus infections, have some sort of neurological problem, either an embolus or a bleed. I mean, it's more of a problem if it's a bleed. Embolus, you can at least go ahead and do the operation if the local complication does occur in the heart. But the big problem is patients who have complicated Staph aureus infection involving the paraannular structures, and they do have a bleed. And these are the patients where it's very difficult to take a decision when to operate. I think still as a cardiac surgical field, we need to sort of try and solve this problem. There has been a paper from Japan by Dr. Okita, where they have said that an agent called nafamostat, they have done a randomized trial, very few patients, and this nafamostat instead of heparin, when used during cardiopulmonary bypass, they did not find significant increase in the area of hemorrhage post-operatively. So that was an interesting paper, but somehow it has not caught on in the world. I mean, as a routine agent that can be used for such cases. But yeah, so it still remains a conundrum in patients who have severe and complicated endocarditis due to Staph aureus and hemorrhagic complications, cerebral hemorrhagic complications.
Yes, well, the guidelines actually says to wait 4 weeks if you can. But this patient, they thought it was a tumor because she came not by fever or anything else, but because she had a dizziness and ophthalmic problems. She couldn't conjugate the view. She was dizzy.
Your case, it was perfect. It was correctly managed. I think if you do serial echoes and you confirm that there is no progress in the local progress of disease, then you could always wait, and it's always better to wait if possible for 4 weeks. The question comes when you can't wait is the question.
We were pretty worried about it because of that image that looked, well, the perforation, the jet through the perforation looked like a pseudoaneurysm or an abscess in the mitral annulus.
Yeah.
So that was pretty worrying for us, but it wasn't compatible with she having no fever, no anything. And this is an immunocompetent person, so that was kind of the way we went.
Okay.
She also, it wasn't an hemorrhage in the brain, but he had surgery, so we were worried about that. So the third case, is there any?
Yeah, there are actually 2 more questions. One is from Juan Contreras. He actually wanted to talk himself, so you can unmute your mic if you want.
Yes.
Hi, Mateo. Hi, Dr. Montes and Dr. Davierwala. I think this is an excellent topic. I have some question in this patient because obviously after the paper that Dr. Davierwala spoke, that is sometimes you can wait in the patient, or sometimes the patient require emergent surgery. The second patient sounds more like a sequela of endocarditis, because if you see the echocardiogram, you have some concern in the imaging, but I don't see any actual embolization. There is no acute vegetation, but he has the sequela of the endocarditis. What was the main reason because you bring the patient to OR in 2 or 3 weeks?
Yes. The last part we didn't catch it. Can you repeat the last part?
My question is, if you see this patient and you say he's not septic, he has a severe mitral regurgitation, looks like a more sequela than active endocarditis. What was the reason because you decided to bring the patient to OR?
Because of this echo here. We weren't sure. Sorry, this is not the echo.
Well, embolism is anyway one of the indications to take the patient to surgery. And in addition, he has a severe MR in a patient with endocarditis. I think it's a definite indication to operate the patient.
If you see the echocardiogram, you can see, yeah, you can see this image that wasn't clear. It seemed like a cavity in there. So, and the report actually said that it was probably an abscess. But we weren't that sure of it because the patient had no fever. She looked good. So, and the blood cultures were negative. The blood cultures.
And she had a severe mitral regurgitation. So that was our indication for surgery.
Yeah, exactly.
So there is another question coming from the public in the chat. Fernando is asking if the valve is not reparable, what kind of valve, of prosthetic valve, do you suggest for this kind of patients, especially in young patients?
Well, in Colombia, we have a problem here because the patients are, well, the place where we operate on that patient is a public hospital. And the patients that go to the public hospital are very poor, non-educated, or rural patients. So we actually use a lot of biological prostheses because they won't follow the warfarin or any anticoagulation therapy after. Most of them go to their home and just never return again. So that's why we are so eager to repair everything, because we really firmly believe it's the best thing that we can do for this kind of population.
There is
From the medical literature, actually, there is no evidence that one or the other valve would be should be performed in endocarditis, except for in the aortic position, patients with aortic abscesses and probably have lesser recurrence of endocarditis if a homograft is used. But beyond that, there is no evidence that use of mechanical or biological valves, one or the other, is better in patients with endocarditis. So usually the decision making should be pretty much the same as for a normal valve replacement. And of course, as mentioned, in special situations in different countries, according to the socioeconomic status, those decisions have to be made differently. Because I come also originally from India, and we had the same problem as in Colombia, and sometimes we had to put in biological valves because there's no way the patients are going to take warfarin once they are back home.
Yeah. So any other question, or we go to the third case?
I think we should move on.
Okay. So this is another case. This is a female of 34 years old. She had history of drug abuse. She had also hypertension, and because of this hypertension and an autoimmune that was in a study, she had chronic renal failure in hemodialysis. And that was 4 months before she came to the hospital. She came to the hospital 1 week for a week, of shortness of breath. And she was diagnosed in fever, and she was diagnosed of COVID-19. So she went to the ICU because her ventilatory part was very compromised. And she developed fever and bacteremia, and the blood culture showed Staphylococcus aureus. So they performed this echocardiogram where we can see a big huge vegetation in the mitral valve leaflet, posterior leaflet. Very mobile. With a severe, almost massive mitral regurgitation. So we took her to the OR, and we, 2 seconds, please. So we took her to the OR to perform the surgery for a valve replacement or trying to repair, because she was a drug addict. And there's also another thing in the echo. They reported defect, a ventricular septal defect. So in the OR, we performed an echocardiogram, and we saw a very small septal defect. And I'm sorry, we have some technical issues. We are going to just connect this. So. Sorry, we just got without battery, our computer. So we just took her to the OR, and in the OR, we saw this pericarditis, like hemorrhagic pericarditis, and we had really severe adherences, especially in the apex. And we found this large vegetation of like 4 centimeters, 3 to 4 centimeters, and a very inflammatory tissue. But she had myxomatous valve. So we actually think that we could remove all that tissue, and we will have enough tissue to repair the valve without being restrained, having restriction or having to change the valve. So we perform a resection of all these inflammatory tissue. And after the resection,
we did a resection and a sliding plasty
and a sliding plasty of the in the posterior leaflet, and we did a commissurotomy of the anterior commissure, and we performed also an annuloplasty. And we don't have also the echo of the postoperative, but it was a very good result for her. She had no MR after that. Sadly, she went to the ICU and she had a good recovery, but after a week, she developed pneumonia. And after that, an emphysema, and she died of sepsis, like a very severe sepsis, uncontrolled. Questions about this one? The reason we did that with we repaired this valve was because she had a history of drug abuse, and also she went to her house, like went and go to her house, and like homeless sometimes, like 4 days homeless. Then she returned to her mother's house and all of this. So it wasn't possible that she would have some warfarin treatment.
So where was the VSD?
Yes, it was a VSD. We also closed the VSD. Sorry, I forgot to tell you.
So where was the VSD? What was the location of the VSD?
Perimembranous.
Perimembranous.
Yes.
Yeah.
And you closed it from the right side then?
Yes.
Yeah.
But the VSD was not due to the infection?
No, it was a congenital VSD. It was almost closed, actually, with the leaflet, but well, that was probably the way of entry to the left side for the endocarditis. So.
And what was the technique of repair you used for the mitral valve?
We did a slide plasty. We took off all the inflammatory tissue and the destroyed tissue, because she had a pretty bad destruction of the mitral valve. But like it was a myxomatous valve, we had enough tissue to do a sliding plasty and then close the commissure, the anterior commissure. And we added an annulus.
We resected almost P1 and big part of P2. But we had enough tissue to do a sliding plasty, but just from left to right, not right to anterior commissure.
Mm-hmm.
I don't know.
You mean from the posterior to the anterior?
Exactly. Yeah. So we move the posterior leaflet, go to the anterior commissure, and we close the anterior commissure. And that was enough to obtain a good result. And then we use a little bit of overcorrection of the mitral ring, but just because obtain a better result.
Coaptation for a best result.
I think that's the right way to go. Like if you can repair the valve despite having to resect in a way that you won't produce a stenosis, in that situation, it's warranted, especially in IV drug abusers, because it's very rare that they totally abstain from drugs in the future. They definitely do come back. But being a drug abuser, why do you think she had or he had a left-sided it was a left-sided infection, not a right-sided, right?
Because she had a ventricular septal defect.
Otherwise, she was a mitral, so I don't know.
Also, it was myxomatous, so, and she was in hemodialysis, so she had bacteremia probably because of that, and then it was a circle.
Yeah. The VSD per se should not, because it's a
It
left
was
to right shunt.
Very, very sick patient, actually. We were going to operate on her, like it's urgent because this is a huge vegetation, and she had 20,000 platelets at that moment and 6 of hemoglobin. So we had to wait a little. And now because of COVID, we are having problems with the hemoderivates, with the platelets, plasma, all of it.
Okay.
People is not donating, so we had to wait for her like 2 days, and it was awful, like waiting if it's going to embolize.
Okay. Do we have any questions from the floor?
There are no additional questions, so I think we can keep going.
Yeah, can go to the next case.
Okay, so this is another woman, 46 years old. She was admitted for 2 weeks of fever, low back pain, and shortness of breath, and she had urinary symptoms. So in the emergency department, they focused the patient like a pyelonephritis, and they started vancomycin because the urine culture had gram-positive coccus, but the blood cultures were negative. Anyway, the patient had a torpid evolution with heart failure, and she required going to the ICU. So in the ICU, they performed this CT, and let's go back. I don't know if you can see, she had a huge abscess and multiple infarctions of the spleen. So we did an echocardiogram as well, and we had this large vegetation in the posterior mitral leaflet. The vegetation was 4 centimeters square. So we started vancomycin and ceftriaxone, and we did a reunion with a multidisciplinary team with everyone, cardiology, general surgery, and us, to see if we could go to valve surgery, like an emergent procedure, or splenectomy plus abscess drainage, and if it was going to be open surgery or laparoscopic. So at the end, we decided the valve surgery was the priority to go emergent because of the large vegetation. And after that, like 48 hours after, they could go to a splenectomy, and they were planning to go laparoscopic, but at the end, they couldn't because it was too large, so they had to go through laparotomy. So this is what we found at POR. We found this big vegetation that we just took out, and we replaced the valve because it was pretty straight. So we put a pericardial valve, bovine pericardial valve. And the operative procedure was kind of simple. And we went out, and the patient had also some disorientation. She was incoherent, so we did this resonance, this MRI, and she had this ischemic areas in here, probably because embolization just before the surgery. So after that, she went to the ICU, and she had this problem, this complication. She had a multilobar pneumonia, but she could be extubated. She had her antibiotics, and she did well. And she went to the hospitalization floor, and she was good. But after a month and a half, after the surgery, she developed acute abdominal pain. And we did a CT scan suspecting complications of the splenectomy. But this is what we find. So let's go back. So this is a large aneurysm of the abdominal aorta. And we also have this kidney that is not having a lot of contrast in it. So you can see here also the same, a huge mitotic aneurysm. This is the reconstruction. And you can see, you cannot see the kidney because the contrast is not going there. And we have a big mitotic aneurysm. It was like 6 to 7 centimeters. This is the angiogram, also showing the kidney is not appearing anywhere. So she was taken by vascular surgery and urology and also general surgery to the OR, and they found a big aneurysm of the aorta and also a big enlarged kidney that had multiple infarctions and an abscess. And the arteria, the arteria was completely thrombosed. So they took this aneurysm out, the kidney, all of it, and they put a patch of Dacron to repair the aorta. This is the piece after the surgery. So the kidney enlarged with infarctions and also abscess. And this is the aneurysm. So after that, the patient actually went very well. She was discharged 2 months after the admission and having a new course of antibiotics. And the TT was normal with the mitral prosthesis completely normal, and she recovered her neurological status completely. So any questions for this case? Also, we perform a pathology of that, and she had related phenomena to the endocarditis, and the arteria of the kidney was completely, she had arteritis in that artery, and it was almost closed. So the infarction wasn't an embolism, but a peripheral phenomena of the endocarditis. And it was a mycotic aneurysm in the pathology.
Yeah, there are indeed 2 questions in the chat, and both of them are related to the brain CT. Juan Contreras is asking if you perform a brain CT as a preoperative protocol for patients with infective endocarditis.
Not usually, not usually.
Okay, and the second question is from Mariano Branchik, is if you looked in this specific case for cerebral mycotic aneurysms preoperatively.
No, preoperative, no, because the patient was in a pretty bad shape at that moment. She was in a heart failure because of that mitral regurgitation, severe mitral regurgitation she had. And she also had, and at that moment she was speaking, but just before we went to the OR, she started being like neurological compromised, like having some incoherent things to say and disorientation. We did that MRI after the surgery.
All right.
In Leipzig, I think we always used to do a whole body CT scan of all patients coming in for endocarditis. I think it's probably just to be on the safer side that you don't miss any major findings, like a mycotic aneurysm in the brain. Putting him on the cardiopulmonary bypass could prove to be fatal. So if you have the time and the resources to do a CT scan, it's always better to do a whole body CT scan, so you know what you're dealing with. It helps you also to identify a focus of infection. At the same time, any of the other complications of endocarditis. It basically gets you more well prepared to deal with the entire case. It's just because endocarditis, you're not just dealing with the heart. I mean, many times we forget as surgeons that it's a systemic process, and it's not only a localized cardiac process that we need to address. So you have to address the whole patient, and that's important in endocarditis.
Yeah, actually, with this patient, she had a series of abdominal CT scans because they were searching for the spleen area. If there was some complication, the control CT scan, and she had the mycotic aneurysm at that time.
Yeah.
So
oh, that's
when
right.
she was perfect, she just developed this. Well, she had this complication of the endocarditis.
Yeah, but he could have very well developed that even before the surgery, right? So in that situation, you would have landed in a big mess.
Yes, of course.
So it's always, I think, better. And that's why we propose an endocarditis team. So if you have an endocarditis team in your hospital, since you're doing a lot of endocarditis, I guess from all your presentation, it would be worthwhile in having an endocarditis team, which would involve a microbiologist, an infectious disease person, cardiologist, radiologist. So you have a specific team, and every endocarditis case is sort of discussed prior to initiation of therapy.
We do. We have a team for endocarditis. Yeah. But what would you do with this patient? She was in heart failure. She had this vegetation of more than 4 centimeters. And
no, I agree with what you've done. It's just that if the only thing I could add for this case is that if you would have done a CT, it would have been, I mean, in general, if you do a CT for all cases of endocarditis prior to surgery.
And if you see something in the CT scan, the brain CT scan for this patient,
if you have a mycotic aneurysm, then you have to think about what you're going to do, right? Then you have to weigh again your options, get a neurosurgeon involved, and you have to weigh the options whether the heart problem is a urgent thing, or obviously a mycotic aneurysm is a sitting time bomb, right? Mm-hmm. Especially if you're going to put the patient on you're going to heparinize the patient completely.
Yeah.
So if your patient is not in failure and there's no complication at the level of the heart, then in that situation, you might want to address a mycotic aneurysm in the brain before you go ahead with your heart surgery, which you would completely miss if you didn't have a CT beforehand.
Okay. Okay. Any other questions?
I think we are kind of running out of time, so maybe we can keep going.
Okay.
How many cases do we have?
8. No, 7. 7 cases.
2 cases.
Just 2 cases more.
Okay.
Okay. The next case is a 53 years old male. He had history of endocarditis 5 years before. He consulted for a month of fever, weakness, muscle pain, shortness of breath. He had a CT scan with septic embolism and left temporary abscess, which was treated with antibiotics, and he had a SARS-CoV-2 infection. The blood culture were positive for streptococcus, and he had TOE with severe aortic regurgitation, vegetation, and the suspicion of annular abscess. So he was referred to our center. In our echo, we found a bicuspid aortic valve with severe regurgitation and an image with a cavity and cell aneurysm just below the anterior commissure. So we went to operation room and we found a type 0 bicuspid aortic valve and vegetation in the area of anterior commissure. We went for replacement. So we resect the aortic leaflet. And we're trying to sew the cavity. And we found all this small cell aneurysm just below the anterior commissure without any fistula tract. And the tissue surrounded looked healthy. So in this case, our approach was try to exclude this perforation, this cavity. We tailor a pericardial path. And then we, with a 5/0 rolling suture, we implant the patch just below the aortic annulus, trying to exclude all the pseudoaneurysm. Then we took a moment to take a picture and this picture. Then we implant biological prosthesis with targeted stitches trying to involve the pericardial patch. Again, reconstruction to the prosthesis. So the result was good, not any irregular flow, and good performance of aortic path. Okay, any questions?
Nope, there are no questions in the chat right now.
Okay, let's continue. The next case is a 26 years old male he was consulted for 2 months of fever, weakness, and shortness of breath. CTE showed bicuspid aortic valve vegetation and severe aortic regurgitation, and he had blood cultures positive for Streptococcus mitis. He received antibiotic treatment for 2 weeks, and then we took a new echo and we found this destruction of the mitral-aortic fibrous body, severe aortic regurgitation, and mass of abscess just in the mid-aortic curtain. So we went to surgery, and this is our approach to the commando surgery. We extended our orthotomy through the non-coronary sinus in order to resect all the mid-aortic curtain. And with this approximation, we implant mitral prosthesis, leaving free the space of the mid-aortic curtain. Then we tailored a fuse form pericardial patch that we folded, and we use the middle part of this patch to reconstruct mid-aortic curtain. Now we have two parts patch. The inferior part is going to reconstruct the left atrium roof. Then we started the aortic root reconstruction that we interrupt in order to implant an aortic process. Then we complete the reconstruction and close the aortotomy. This is the final view. This is our 6th case. Questions?
No, there are no questions. So yeah, you still have a case, right?
Yeah.
Yeah. Okay. Yeah.
I think we go ahead, finish the cases, and then just do a short discussion.
Yeah, sure.
Okay. And next case is a 50 years old male diabetic. He consulted for 5 weeks with of fever, muscle pain, weight loss. He came from an endemic zone of malaria and dengue, and they were scarred. The doctors found an aortic murmur, so they referred to our center with suspicion of endocarditis. So this is the case. Our TOE found some small vegetation, maybe thickness of the mitral aortic curtain, severe mitral aortic regurgitation. Oh, sorry. So we went to operation room and we found a complete destroyed mitral aortic curtain with a lot of infective tissue, inflammatory tissue. He had dilated aortic root with 48 millimeters diameter. So we decided to go to commando surgery and dental procedure. We resect all the infected tissue of mitral aortic curtain and the anterior mitral leaflet. Try to resect all the infected tissue. Then we resected aortic valve leaflet. We preserved a posterior mitral leaflet. We dissected left coronary buttons, preparing for dental procedure. Now the right coronary button. Aortic wall was very thin. Now we use plate sheets from anterior to posterior trigon in the posterior annulus in order to implant mitral mechanical prosthesis. We measure the valve and we left free the part of the mitral aortic curtain, maybe a third of the circumference of the second ring. Then we implanted a mechanical valve in mitral position. And then when tailored a fusiform pericardial patch that we folded. And the middle part went to reconstruct the mitral artery fibrous body. Very careful at the point of the commissure of the trigons, you have to make deep stitches in order to avoid any paravalvular leaks. So again, the posterior commissure, deep stitches. Now the inferior part of the patch was going to reconstruct the left atrium roof. You have to be very careful with this suture line because any bleeding of the zone is very difficult to correct after the end of the procedure. And we use the superior part of the patch to start the reconstruction of our root and the fibrous body. And then we stop in order to start the implantation of composite graft. These plate stitches, we usually go outside from outside to inside in the pericardial patch in order to avoid any distortion of this patch. And we are careful to leave enough space between mitral and aortic valve. Now we complete the implantation. Again, from outside to inside. On this point, the annulus, the new annulus is slightly higher. Then we measure a proper composite graft. We implant coronary buttons, left coronary, right coronary button, and then the distal anastomosis. Okay, and our final case is a 28-year-old male with 2 months of 2 months before he was diagnosed of endocarditis because of thrombotic occlusion on LAD. He was treated by thromboaspiration with glucosol. After that, he went to surgery and they did a aortic valve replacement with carbomedics 23 mechanical valve. So he completed antibiotic treatment, but he required a readmission because he had air failure and fever. So GOE showed massive aortic regurgitation caused by prosthesis dysfunction and mitral-aortic curtain abscess. So they referred to our center. So this is the case. Big destruction, aortic valve destruction, mitral-aortic abscess, mitral vegetation. So first we, in the operation room, we found a small cavity just below the left coronary ostium. Then we expand, resect the aortic prosthesis, and we found a quite destructive endocarditis with a lot of infected tissue. We went for a commando surgery. We resect all the mitral aortic vertebral body with resection of all infected tissue. But at this point, we found the unattached anterior trigon with a cavity extend to the interventricular septum. Oh, so. Is the cavity and the return. We try to reattach the anterior trigon with plated suture. And when the trigon was in a more proper situation, we complete the reconstruction with a Dacon patch. Now you can see the patch just very close to the left coronary ostium. So we continue the commando procedure. We implant a mechanical mitral prosthesis in a usual way, and we tailor a patch to reconstruct the mitral aortic curtain. Then we went to reconstruct the left atrium roof. Now, and then the aortic root. We implanted a proper mechanical aortic valve. Avoided malfunction. And then we finish the reconstruction and close the aortotomy. Hemostasis is very important in this kind of surgery. Okay.
Well, we have a really few cases of commando, not the 127 that Dr. Davierwala published. We only have 7 cases that this has been in a year and a half only. And this was actually in the middle of the pandemic, so we had problems with, for example, the Dacron patch. You will be wondering why we use a Dacron patch instead of pericardium in that last case. Well, we couldn't have pericardium at that moment because it just started, the pandemic started, and we had no pericardium at that moment, just Dacron. So our patients are pretty young. We have a medium age of 34 years old, and they all went to commando procedure because of endocarditis. We have three redo procedures, and we only had, and one was the second redo procedure, actually. We had a patient that had multiple interventions for bleeding, but this was a special case. He had an intoxication. He tried to kill himself taking paraquat, and he had a liver failure, and he skipped the pulmonary fibrosis. We still don't know how. And of course, with that liver failure, he had to be reintervened 8 times for bleeding. And we had one neurological problem, not an accident, cerebrovascular accident, but an ischemic, diffuse ischemic encephalitis. And we had no infection problems, no recurrent endocarditis in our series. And in the medium term, because it's just like a year and a half that we started this procedure, we had 2 patients that died. One died because he didn't stop drinking. He was drunk and he had a car accident and he died. And the other patient was admitted because of sepsis, and they suspected COVID. It was the first peak of the pandemic in that time. And this is a problem for us in this population because we already spoke about the problem to have patients with biological prosthesis because they won't take the warfarin. And we also have very young patients, and these young patients won't keep the controls, the consultations, or the care for themselves. So we have one that just went to a clinic for rehabilitation of alcoholism, and another that killed himself in a car accident because he was drunk. So this is kind of our populations.
Well, that was an excellent presentation. I'm very well done, and congratulations to you on some excellent surgery. The last 3 cases were really complex, especially the last one, and it's great. I mean, you've got great results to back that up. Looking at the technique that you used for the commando operation, I mean, it's pretty much similar to what we do, except I had just one comment. The patch that you use, the double patch, what I do is normally before I push the valve down, my valve sutures, I pass them through the patch and then through the sewing cuff of the valve, so that the 2 corners of the patches are embedded between the sewing cuff of the prosthesis and the native annulus. So in that way, you pretty much eliminate the risk of having some sort of a leak at that point. I mean, if you're lowering the patch, if you're lowering the valve first and then putting the patch on top of the valve, I think as you did, there are chances that you might sort of have a leak at that point if you're not careful. I mean, know how to do it, but it's just for the general audience who are not used to doing endocarditis cases. It's probably better to, unfortunately, I don't have the video of my technique on this computer here at the hospital. So the last stitch, which is taken at the trigone, so the left fibrous trigone and the right fibrous trigone. So it's passed through the native annulus, then it's passed through the patch, the double patch, and then it's passed through the sewing cuff of the valve. And then you can go down. Another technique which you can also use, which I think Dr. Torsten Dunst, he uses, and even Michael Borger now uses in Leipzig, is they construct the patch and the valve initially, even before passing the sutures. So they stitch the patch to the valve, that 1/3 area of the anterior part of the sewing cuff, and then lower the valve down. So there are different ways you can do it. But my only suggestion is that if you place the patch between the valve, prosthetic valve, and the native annulus, you're much safer in a way to prevent any kind of paravalvular leak or even leakage out. If it leaks outside, you're done. It's very difficult to fix that even when you're on pump. So it's very difficult to get to that area. The second thing is other important, like in the third case which you showed, in the last case actually, of the UFO, where you showed that the coronary artery the button was extremely close to the annulus. That's right. Yeah. So in a redo case, so if you're doing a second, third time redo, it's sometimes extremely difficult to mobilize the coronary arteries to get them to the graft. So one option in that situation is that you can take an oversized graft so that the graft itself can go to the coronary artery. If you have a bigger size graft, that's possible if the coronary artery is not, the button is not very far away from the native aorta. But if it's pretty far away, like it's stuck to the posterior part of the pulmonary artery sometimes, and it's impossible to get it off the pulmonary artery, in that situation, you can do a modified Cabral operation, in which case you sew I prefer a ringed PTFE graft. You take a 6 or 8 millimeter graft and you sew it end to end with the left coronary artery. Bring it posterior to your aortic prosthesis, and then sew it onto the right lateral wall of the aorta. So that's a modified Cabral approach which you can use, especially for the left coronary artery. The right coronary artery, you can also use a Cabral technique if it's difficult to get it onto it. But most commonly, the right coronary, you are able to get it to the, and it's usually higher, so it's possible to get it as a native button. So that's those are the two things which from your cases I got, and I mean I had two comments. And another technique which you can use sometimes when it's a disaster, and you basically, once you reconstructed the annulus and the the non-coronary sinus, it's not always that you get a round shaped annulus. I mean, it's sometimes sort of skewed, and it's sometimes like a square or an ellipse or whatever. In such situations, if you're directly sewing, if you're doing a Bentall, and if you're directly sewing the valve, the rigid valve, you have to sometimes you have to sew it directly to the LVOT muscle, because the entire annulus is destroyed. So in such situations, if you're going to sew the rigid valve directly to the muscle, there's always a chance that it might tear off, because you're sewing a muscle to something which is absolutely rigid. And once the heart starts beating, there are chances that your sutures through the muscles may cut through the muscle. and then you land in a massive problem. So what I usually do in such a situation is you just take the prosthesis, so just a Dacron graft without any valve, and you sew the Dacron graft first to the muscle, and the Dacron graft is very supple. So the Dacron graft will adapt to the muscle, to whatever you stitch it to, because it's not rigid. And then you mark the level of your coronary buttons, where they are going to be approximately, and then sew the valve into the graft as a second. I mean, obviously it increases your clamp time, but it makes a safe operation. And then you sew the coronary buttons, but make sure that you know where the coronary buttons are going to come, at what level. It should not be that your valve is high and now you're stuck with the coronary buttons probably going under the valve. You cannot do that. And if you even get stuck with such a thing, then again, you can do that Cabral option. If you're stuck with the valve higher up than your coronary buttons, then you can again put the two PTFE grafts and sew them onto the aorta. So these are different tricks where you can get out of trouble, because these operations can go anywhere. Like you start off thinking, okay, I'm going to do this, and suddenly you will find, oh, I'm in a big mess here and I don't know how to get out of it. But if you have all the options available and tricks up your sleeve, then pretty much you can get out of any difficult situation. So those are just a few comments that I had, but otherwise the operations were excellent, and that is the way to do it. I mean, do we have any questions from the floor?
Yes, I have one question, please.
Yes.
Hi, I'm Hernan Fernandez. I'm from Cartagena de Indias, and I need your help. First off, let me congratulate both of you for such an outstanding presentation that came as a godsend. It's like a ring on a finger. As we speak, I have a 77-year-old male patient who is hypertensive, diabetic, smoker. His debut was 10 days ago with a syncope. The chest X-ray showed an aortic aneurysm in the descending aorta, and the angio-CT showed a saccular aneurysm in the aortic isthmus with a mycotic appearance. He has no history of previous trauma. Both the blood cultures and the urine culture show Staphylococcus aureus and Klebsiella. Since then, he is in antibiotic treatment with vancomycin and gentamicin. He is stable. He's in renal failure. His creatinine is 2.5. He is with no mechanical ventilation. He's with a low dose of noradrenaline. But today they performed a transthoracic echocardiogram that showed a 9/17 millimeters vegetation in the ventricular side of the ventricular septum. So that's what I need your help, your advice. This is a difficult case, and I would love to hear from you what are your recommendations in this case.
So you have the vegetation and the mycotic aneurysm.
Yes, the mycotic aneurysm, he had blood cultures positives and urine cultures, and now today we were planning to perform a TVAR next week because the patient is stable, but with the new findings of the vegetation in the aortic, in the ventricular septum, we don't know what we should do. The brain CT scan was done, and it didn't show any neurological infection that we know so far.
But the mycotic aneurysm is in the arch or in the descending aorta?
In the isthmus, in the aortic isthmus.
Isthmus. But doing a TVAR in a mycotic aneurysm is not the best idea. Eh?
No.
Endocarditis.
Yeah, because it will get infected though, and then you'll land in more problems than you already are.
The TVAR after.
Yeah.
The plan was to eradicate the infection. So we are waiting for more days, one couple weeks to do that. But we know that in mycotic aneurysm is contraindicated.
Yeah.
Where is the vegetation?
The left ventricular outflow tract.
Is in the ventricular side of in the left ventricular side of the ventricular septum, 9/17 millimeters. It was maybe the cause of the syncope.
You sure it's a vegetation? No, not a thrombus or something. Is weird to have a vegetation in the septum.
But it relates to the case because he's infected.
Maybe arising from the aorta, from the cusp. I mean, obviously,
we don't really know.
It's very difficult to comment, but it would be good to see the pictures as well as especially the pictures of the mycotic aneurysm, because I would prefer to take care of the mycotic aneurysm surgically rather than by TIVA.
Yeah.
Okay.
You'll have.
Yeah.
Thank you very much. Appreciate.
Yeah.
Okay.
Okay, so Piroze, you wanted to share something to finish.
Yeah, I just wanted to. It's just a coincidence. I did a UFO just a week ago, and I just wanted. I don't have the videos of the procedure. Just it's an interesting echo, and and when you see such a picture, you upfront can say that you will need a UFO operation. So I'll just try and. Can I share my screen or?
Yeah, sure. Do you want me to stop recording the presentation? I don't know if you have the names hidden of the patients.
Yeah, just one sec. I need to get back into the.
So I will just stop recording, and then you can show the images maybe, because I don't know if you have the names hidden.
Yeah, just a sec.
Okay.